Hello everyone, my name is Alex Ralphie, and welcome to the lecture on endocrine pharmacology. This is the last section of our endocrinology lectures, and if you have not done so already, I suggest you review the physiology section to get more out of this one. Just so you are aware, I like to ask questions throughout my lecture, and to get more out of your learning experience, try to answer them yourself without looking in the book. However, if you get a question wrong, flag the subject for review later on. Remember, when studying pharmacology, try to pay attention to the endings of the names of the drugs to better remember what class they fit into. Let's begin by talking about drugs used to treat diabetes. The treatment strategy differs depending on the type of diabetes you are treating, with a caveat that almost all diabetics will eventually require insulin. In type 1 diabetes, patients are encouraged to maintain a low carbohydrate diet and are prescribed insulin to replace the insulin that is no longer produced by the pancreas. In contrast, in type 2 diabetes, diet and exercise to decrease weight are often the first-line recommendations. If this fails, patients will be started on oral agents, and then in the case that these fail, insulin is added. Lastly, in gestational diabetes, like type 2, diet and exercise must be encouraged. However, unlike type 2, oral agents are not used during pregnancy, as insulin is a preferred agent to control hyperglycemia. Let's start by reviewing the different types of injectable insulin patients may use. As you can see from the graph and the table on this slide, there are 4 categories of insulin which are organized by onset and duration of action. Do you remember which 3 rapid-acting insulin formulations are available? Lispro, Aspart, and Glulisine. The way I remember these drugs is by using the mnemonic lag, since they are fast-acting and these do not lag. Usually these are taken right before meals. Regular insulin, shown in green on the graph, is fairly rapid-acting, though not as quick as the previous 3. It tends to last longer as well. The mainstay intermediate-acting insulin is shown in yellow and is NPH, or neutral protamine hagedorn. Lastly, the 2 long-acting insulins, their effects shown in orange on the graph, are glargine and detamir. Okay, time for a flash quiz. Type 2 diabetics will often require injectable insulin at some point during their disease course. What is that due to? This is due to beta cell burnout. Type 2 diabetics often have components of both peripheral resistance and beta cell destruction. Briefly, I want to go over what the effects of insulin are. Remember, it binds to insulin receptors, which have tyrosine kinase activity, and this brings about different effects depending on tissue type. In the liver, it stimulates the conversion of glucose to glycogen. In muscle, it increases glycogen and protein synthesis. In addition, it will also increase potassium uptake. In adipocytes, it increases triglyceride storage. There are several different classes of medications for type 2 diabetes, and it is important to know the class, examples of drugs, their mechanism of action, and important side effects. We will review this by going through this table. The first class of oral hypoglycemics is the biguanides, in which metformin is the only drug. Metformin activates AMP-activated protein kinase, or AMPK, by elevating cytosolic AMP levels. AMPK is an enzyme which has important roles in insulin signaling and metabolism. The downstream effects of this is decreasing gluconeogenesis, increasing glycolysis, and increasing peripheral glucose uptake, which are all things we want to happen in the setting of diabetes mellitus. The major side effect to be aware of is lactic acidosis. Therefore, this drug is contraindicated in renal failure. Importantly, metformin does not require beta cell function for efficacy, so it can be used in type 1 diabetics, in addition to being first-line therapy in type 2 diabetics. The most common side effect, however, of metformin is GI upset. Here is a visual representation of where biguanides exert their effects. Remember that it decreases gluconeogenesis and increases peripheral uptake in muscle. The next class of oral hypoglycemics is the sulfonylureas. Sulfonylureas act on the beta cells of the pancreas to stimulate insulin release. The idea behind this is that you can increase the output of endogenous insulin instead of having the patient take regular shots of insulin. The mechanism involves closing potassium channels in beta cells, which causes the membrane to depolarize and opens voltage-gated sensitive calcium channels. The influx of calcium ions triggers exocytosis of insulin granules, hence insulin release. Sulfonylureas also contain sulfur groups. Therefore, if you have a patient with a sulfur allergy, you'll need to avoid these drugs. There are two generations of these drugs. The first is rarely used today. The first generation includes tolbutamide, tolazamide, and chlorpropamide. The mainstay thing you need to know about these drugs is they are associated with disulfiram-like reactions, meaning if you take these drugs with alcohol you can have headaches, nausea, and vomiting. Of note, chlorpropamide is associated with SIADH. Here again we see our diagram, but the action of sulfonylureas will be on the pancreas. These are insulin secretagogues and will stimulate insulin release and bring down blood sugar levels. Second generation sulfonylureas include glyburide, glimepiride, and glipizide. Because sulfonylureas act to increase the release of insulin, the major side effect is hypoglycemia, and this risk is increased in patients with renal failure. Now we mentioned that these drugs are not to be used in people with sulfur allergies, but there is another option. We have non-sulfonylurea secretagogues, meaning that they act in the same manner as the ones described above, but they do not have a sulfur group. These are the metaglutinides and include repaglinide and nataglinide. The thiazolidinediones, which include pioglitazone and rosiglitazone, act to increase insulin sensitivity in peripheral tissues by binding to the PPAR gamma nuclear transcription regulator. Major side effects of these drugs include weight gain, edema, and hepatotoxicity, and they are contraindicated in patients with heart failure. In our diagram, where are the thiazolidinediones going to act? Right, on peripheral tissues, specifically adipose tissue. The alpha-glucosidase inhibitors such as acarbose and miglitol are taken at the beginning of meals, and they act by blocking the alpha-glucosidase enzyme on the intestinal brush border. This prevents hydrolysis of dietary carbohydrates and minimizes the amount of sugar that actually gets absorbed by the stomach. However, with this leftover sugar in the colon, which is not absorbed, the bacteria are happy to eat it up, and this leads to the side effect of bloating and gas. In addition, since sugar can act as an osmotic agent, these patients may also have diarrhea as a side effect. Uncommonly, one can also see hypoglycemia. Now back to our diagram. Where will alpha-glucosidase inhibitors have their effect again? Great, on the gut, preventing dietary absorption of carbohydrates. The next drug I'll mention here is actually injected. Pramlintide is an analog of the protein amylin, which is normally secreted along with insulin by beta cells. The main function of pramlintide is to decrease glucagon secretion, and in this way it can delay gastric emptying. Its side effects include hypoglycemia, nausea, and diarrhea. Glucagon-like protein 1 analogs such as exenatide and liraglutide act to boost insulin release and reduce glucagon release. Occasionally these patients may develop pancreatitis. In our diagram, we see that GLP-1 analogs affect the pancreas by increasing insulin secretion. Also, don't forget, they also reduce glucagon release. The last group of medications are the dipeptidyl peptidase 4, or DPP4 inhibitors. DPP4 is an enzyme that inactivates GLP-1, Therefore, DPP-4 inhibitors will act to block the inactivation of GLP-1, resulting in the same effects as the GLP-1 analogs, as described earlier. The DPP-4 inhibitors include linagliptin, saxagliptin, and sitagliptin. So, just like GLP-1 analogs, DPP-4 inhibitors affect the pancreas by increasing insulin secretion.